Hi everyone, welcome to part 2 of our Coding with Miss Melanie coding segment for our coding clinic review with our class 2030 CPT and professional based coding. This is our review of questions sent throughout the week and for week of coding clinic with February 12th of this year. And today is Valentine's Day, so happy Valentine's Day edition. Okay, so we've already talked in our main coding review about some of the coding process questions that involved abstracting, knowing who you're coding for, and identifying details. And I wanted to get started. I have a list of questions that we're going to cover today, and I also wanted to code with you guys the example that we used in our first section where we reviewed a chart to see for the colonoscopy on a patient who had a high-risk colonoscopy screening. So let me pull that up. This particular question was pulled from your Chapter 30 review from your assignment for HCPCS coding. And so the first thing you would know when you were coding that is that this code would have come from your HCPCS book. Now, one thing that you will pay attention to is that HCPCS can be combined with CPT modifiers and vice versa. And so let's go through that scenario one more time, this time looking in our coding book to see exactly what would we need for procedural coding. Okay, so just to kind of re-review, we had a patient that came in today who had indications of ulcerative enterocolitis and was here for a colonoscope. I'm going to start by writing down the procedure of what it is. And presuming I didn't know that this needed to be out of the HCPCS, I would look in both the HCPCS and the CPT to see exactly what is in here. Now, one thing that I'm going to let you know, for a colonoscope in the HCPCS, there's a very small section and they're all screening for cancer. And so you want to keep that in mind. You're not going to find it under the term colonoscope. You're going to find under the main term of what it is, which is a screening. And so I'm going to look in my HCPCS. I have the 2018 edition professional from the AMA. If you have a different edition, you'll be on a different page than I will. And if I look for colonoscope, I'm not likely to find that. So colonoscope is not in here. Double checking. I do, however, have colorectal screening for cancer, and it gives me a list of codes. And so when I go in here, luckily that was right next to each other. Colorectal, is that where we're looking at? Yes, it's the colon and the rectum. So I'm going to look at codes GO104 through GO106. And make sure you put those dashes through your zeros when you're writing it down so you don't accidentally write down an O instead of a 0. In fact, I should be saying it as G0, not GO. And then we also have another code set, G0, 120 through G0, 122 and G0, 328. Now, because we did look at this earlier already, we know that it was a screening. And so very likely the colorectal screening is going to be correct, but you want to identify, how do I know that I'm going to be using this particular code for the HCPCS versus a CPT? And excuse me as I step off the screen, I'm just moving some of the books we won't be looking at for PCS and diagnoses. Okay, so how do I know? Well, number one, you may remember that the G section, since that's the only section that was in the HCPCS, you may remember that this is for Medicare-only services and some insurers that accept Medicare services. So if I go to the beginning of my G section, which in my book is found on page 214, and part of the purple section on the band for G codes, I will find that G codes, as well as services with K and Q, in the level 2 coding are reserved for CMS assignment. Okay, so in other words, Medicare and Medicaid services, because both of them fall within CMS. And then it gives you some specifics as to these being temporary codes. Now later on in our class, we will be looking at specific screening and preventative services that are permitted with CMS. And I'll be giving you guys an activity to go in and look at those very specifically. Just know that if you're in this area, you're going to know if those are something that you regularly bill for. And you'll know by looking at the fact that the patient is 71 years old that we are probably dealing with a Medicare patient. Of course, we should never assume, so you would look at his or her chart and determine that yes, this patient is with Medicare, or no, they are not. Now, before I say HCPCS, let's take a glance at the CPT book and see exactly what is the details listed for a colonoscope. So here I'm going to go to colonoscope. You may decide to try screening, and that's fine. Let's see. So when I get to colon on page 633 of my book, which is the 2018 Standard Edition CPT from the AMA, you guys should all have a different one if you're part of this class, so forgive me for a different page. Under colon, colonoscopy does say see colonoscopy. So I'm going to keep going, and I find colonoscopy, and it breaks it down. This is one of the things that's going to tell you what to abstract in the note. In the alphabetical, colonoscopy breaks down first off of flexible versus follow-up intervals through a stoma, placement removal, submucosal injection, and ultrasound. So notice that, I think those are all through the stoma. Okay, so I have flexible versus follow-up intervals through the stoma. None of those are screening, but that's okay because we may have something in here that tells us this. Keep in mind, if this was not a Medicare patient, we would still be coding this exact same procedure out of the CPT, even for a screening purpose. So it's important that we look at both. In this case, that's where that instrument detail is going to come in handy because it told you the type of instrument that was used was an Olympus Video Colonoscope CF 100L. And if you didn't know what that was, you could look it up and say, what exactly is that? And it would be a flexible colonoscopy, flexible colonoscope. So I would go in through colonoscopy, flexible. I would also know that that was more appropriate than through a stoma or through follow-up intervals, okay? Then I would go in and I would say, okay, well, what is it? And I have the options of ablation, band ligation, biopsies, collections of specimens, decompression, diagnostic, dilation, hemorrhage injection, mucosal retraction, placement removal, and ultrasound. Okay, and so none of these are exactly screenings, which may also take you to your HCPCS book if your insurance accepted it. So that would be one thing to keep in mind. Also, you may look under screening. If I don't see something, I might look up all of these codes and I can kind of see that they're all in the same 453 range. And so that's one thing I'm gonna write down is 453 and then just kind of XX for myself to say, I don't know what the rest of it is, but all of these are in that same range, okay? I would also continue glancing, make sure I didn't miss anything. I'm thinking it's going to be under diagnostic, 45378. Even though it's a screening, it's not to diagnose something. That might include both. And so when you get into that code, you'll look for that. And then, of course, because we didn't find it there, we do want to look for colorectal screening or just screening. So I'm going to kind of glance for that. Colorectal. Coli. And of course, this is when we start singing the alphabet in our head. Okay. So I don't see colorectal. So I would glance and see, is screening in here? And it very well may be under screening, as that is an action word. What's the purpose? Action. The action is to screen. And so since I didn't find that under the anatomy or the name of the procedure, I have to think of other main terms that this would fall under. And I went too far. Okay, so screening. SC, screening for a drug, and that's all that's listed. So in that case, I'm going to look at all the options in front of me and say, but do any of these apply appropriately? Now, since I've already pulled it up, let's look at the G codes that are in Medicare. The options are GO 104 through 106 first. So G0104, colorectal cancer screening, flexible sigmoidoscopy. Covered once every 48 hours for beneficiaries over the age of 50. So that's kind of cool. My HCPCS gives me that detail. Yours should too. GO 105, colorectal cancer screening, colonoscopy on individual at high risk. Ooh, remember that key factor. High risk and location is a difference there. And G0106, colorectal screening, cancer screening, alternative to G0104, screening sigmoidoscopy with a barium enema. Okay, so did we do a barium enema? And so those would be some of the things. If I didn't already read through that note, I would say, okay, what's the difference between 104 through 106? And I would say location. That's something I'm abstracting. And the barium enema. Okay, that was the two biggest things. And then we have G0120, colorectal cancer screening, alternative to G0105, screening colonoscopy, barium enema. Okay, so again, kind of that same detail here. Oh, and high risk, that was the other thing, high risk. G0121 is for cancer screening, colonoscopy, individual not meeting criteria for a high risk. 122 is colorectal screening, barium enema. Okay, so what's the difference between 106 and 120 and 122? 106 is colorectal cancer screening, alternative to G0104, which is the sigmoidoscopy, barium enema. So barium enema, not a high risk. G0120, colorectal cancer screening, alternative to G0105, which is individuals with a high risk, barium enema. And then G0122, colorectal cancer screening, barium enema. There's no indication whether or not this is an alternative or with a high risk. It's just simply a barium enema. So that's your difference. So you should identify the difference between those codes, even though we already know ahead of time that we didn't do a barium enema, because you might have and you would need to determine the difference. Once that's determined, then you're going to go back and you're going to look at any other codes. So G0328, and that one is a couple of pages later, G0328, colorectal cancer screening, fecal occult blood test. So that's where they take the stool sample, and they're not doing that in a colonoscopy. So that one I can just mark off the board right away because we know it's a colonoscopy, not a procedure. Okay? In fact, we're going to end up marking off 120 and 122 because there was no barium enema. So we can mark that off as well by looking through the note and saying it. Then when we looked at the CPT codes, 453XX, with the idea that 45378 might be correct, we'll go there. There's a lot of stuff in this section. I love it. Okay, so I'm going to look first at 45378. And I'm also going to pay attention because I'm looking at a full section. What is the section to? Okay, so 45378, the first thing I should do is find the code and then look at where is that section at. So 45378, colonoscopy, flexible, diagnostic, including collection of specimens by brushing or washing when performed as a separate procedure. And then it says do not report in conjunction with details for colonoscopy with decompression, details, and then it moves on. Now before I look at that, that's a diagnostic. This wasn't diagnostic. So I know again that that's not correct. I'm also going to go to the very beginning of that section, which is going to be on a previous page before 45300. And I'm going to determine that this is the endoscopy under the surgical or the digestive system. Endoscopy gives me details of the differences between a proctosigmoidoscopy, a sigmoidoscopy, colonoscopy, and colonoscopy through a stoma. And that's important to read so you identify definitions. I'm also going to glance and say, is there anything else about screenings? In fact, there is in the guidelines. It says right here, when performing a diagnostic or screening endoscopic procedure on a patient who is scheduled and prepped for a total colonoscopy, if a physician is unable to advance the colonoscope to the cecum or colon, small intestine, anastomosis due to unforeseen circumstances, you can report 45378. Ooh, that's the code I had. Or 44388, colonoscopy through stoma, definitely not mine, with modifier 53 and appropriate documentation. So that's for a discontinued service. Now, that tells us that yes, there is modifiers and there's a detail about that, but I'm going to talk to you in just a moment about what that is. Okay, so excuse me for a moment as I go off screen. What first thing you want to do is you want to look now at the notes and say, is this a patient that's with Medicare? And should we be doing the screening since that was in fact more appropriate? Or is this a patient that is not with Medicare and therefore using the 45378? And so we would go back here and say, who am I coding? Where am I at? I would look at that detail. And in this case, we were coding for HCPCS in this class. And so we should eliminate both of the CPT codes from here. But I wanted to take you through the process of how would I look for that and determine the difference. Okay? Keep in mind, we're going to come back there because we talked a little bit about modifiers. We want to look at that. Okay, so we go back to the original note that we looked at earlier. The procedure, patient was a female, 71-year-old female, admitted to the surgical center for colonoscopy due to her chronic enterocolitis. She is at high risk for malignancy of the colon and therefore screening is being done. So if we remember earlier, we said what's the difference between G0104 through G0106, and the differences included high risk, location, and whether or not a barium enema was done. In this case, we eliminated that a barium enema was not done, and we say, is she a high risk? Yes. So which of those codes applies to high risk? Okay, so that was how I know what to abstract, because I looked at the codes first to say, what do I need? Oh, I need to know the difference between these three factors. Okay, so I would go back and say, okay, G0104 was not high risk, G0105 is, and G0106 had a barium enema. Okay, so in this case, I could actually stop here and say that my code should be a G0105. Because I know this patient is a high risk. Also, the fact that it's a colonoscopy. Now, I'm going to have to go back though because of that modifier. And it even says here, screening colonoscopy covered once every 24 months, may use modifier 53 if appropriate from the physician fee schedule. Let's look for a moment at modifier 53 to determine if that's the best modifier. So, glance through the rest of the note. Look and see if there's anything different. We did have a patient that was on anesthesia who had a colonoscopy. We've coded the colonoscopy. We are not coding the anesthesia, but it's important to know, and I'll tell you in a moment. We continue to go on, and we say it was aborted, so it was a discontinued service due to a medical condition. And we're going to look at our modifiers now in CPT to see what modifier needs to go in, because the full procedure stopped at the sigmoid, not at the colon. Okay, so that's why we need that modifier, because the procedure was not only discontinued, but it wasn't completed to the best of the ability we could code it as. Now, if I look at modifier 53, I'm going to find that in here for a discontinued procedure. And I'm going to read through this, and it's very important you look at the modifiers until you're familiar with them and read through the entire description. Keep in mind, all of this process is about how to learn and how to know what to look for. Once you're doing it on a regular basis, it won't take you as long. A discontinued procedure under certain circumstances, the physician or other health care professional may elect to terminate a surgical or diagnostic procedure due to extenuating circumstances or those that threaten the well-being of the patient. It may be necessary to indicate the surgical or diagnostic procedure was started but discontinued. That does apply. But keep reading. The circumstance may be reported by adding modifier 53 to the individual for the discontinued procedure. Note, this modifier is not used to report an elective cancellation of a procedure prior to the patient's anesthesia indication or surgical prep in the op suit. For outpatient hospital ambulatory surgery centers, we are in ambulatory surgery. We said that in the note earlier, okay? Reporting of previously scheduled procedure or service that is partially reduced or canceled as a result of extenuating circumstances or those that threaten the well-being of the patient prior to or after admission of anesthesia, see modifier 73 or 74 instead. So that, if I read that entire blurb, would have told me the proper modifier, in fact, should be 73 or 74, not 53. And if you got that wrong when we did that part of the chapter review, that was why. If I go to 73, this is discontinued outpatient hospital or ambulatory surgery center procedure prior to administration of anesthesia. In this case, the patient had it for 30 minutes, so it's not prior. And I don't have to read the whole blurb, but I can if I'd like. 74, discontinued outpatient hospital ambulatory surgery center procedure after administration of anesthesia. So the biggest difference there is 53 can be used on procedures in the office, but if it's an ambulatory surgical center, you need to use code specific to that. And so in this case, I'm going to put G0105-74 for discontinued outpatient ambulatory surgery center after administration of anesthesia. And this is my final code. Okay, so that's it for this particular question. Not all of these are going to be as long. Bear with me while I erase the board here for us. I had a couple of additional issues with connect. Some of the wording in connect is a little weird with some of the questions on the exams, and they don't always make sense in terms of coding, or they don't always match what they actually should be saying. We are using a brand new book, and unfortunately we're trying to get rid of those snags. And so if I've missed something and I've had a few things sent to me, please take a screenshot of the question and send it to me. I have a couple of them in there, especially on some of them where the wording is very specific to the chapter work, but not necessarily how it should in fact be. So if you see something with wording that's weird, just go ahead and send that to me and I'll take a look at it. I had one question this week on pathology. One of the connect questions was, and I'll pull this up as we talk, kind of going down a little bit here. Okay, so in our exam number 3, surgical pathology levels are determined by what? And you had the options of type of exams, size of specimen, complexity of surgery, and anatomical site and descriptive terms. This goes back to our laboratory section for surgical pathology. In the 8300s, I believe, is the section you should be in. And the way that it is defined, if you're not sure, look it up in the book and say, how is this determined by? What is the differences between the different codes in determining how to code this? That's what they want you to answer. Your answer here should be the anatomical site and descriptive terms. And for surgical pathology, which I'll be on in just a moment, as I flip through the pages. So for surgical pathology, I'm going to tell you without finding it, it's categorized as level 1, which is your gross exam. That's your physical exam. But all the other levels, here it is, for 88,300 through 88,309, all of these are identified based off of first, where was it? And second, what is the type of surgical specimen? And so the details. So anatomical site and descriptive details was the correct answer for that one. Okay. I had another question on how do we identify the P status? We had one in here specifically. I won't make you guys wait while I look at it, but let's talk about anesthesia P codes. Okay, if you turn in your HCPCS over to our modifiers section, you can look at those in more detail. And we have here our P status codes, which are identified for every anesthesia patient. And actually, these details in HCPCS are exactly how we have them already. We have a normal healthy patient, a patient with mild systemic diseases, a patient with severe systemic diseases, a patient with severe systemic disease that is a constant threat to life, and a morbid patient, moorbound patient who's not expected to survive, as well as your brain dead. Okay, so you go from P1 to P6, and the biggest thing is documentation is key. Remember, if it's not documented, it didn't happen. So every patient is going to be at least a normal happy patient. They're either normal or they're not. And that's not a happy thing. So we go from normal patient, what is a systemic disease? Okay, that's the first thing. So for P2 through P4, yes? P2 through P4 is a systemic. And it's important to say systemic means pertaining to systematic or pertaining to the full body system. And so these are diseases that, a patient has which have to be affecting the entire body. So if I have a scratch to my hand, that's not systemic, but if I have something like diabetes or hypertension, that can affect every part of the body. And so because it can affect every part of the body, it's considered systemic, and therefore it's either stable or not specified as severe, or it's a severe condition, which is just kind of specified as uncontrolled or having issues, or it's a very severe issue that is a constant threat to life, and that has to be documented. This is a constant threat to life, or something in the terms of, hey, this patient's getting this done and they have uncontrolled hypertension that is constantly having issues and complications to the heart, which is concern for, and something about it has to say they could die from this, and it's constantly having issues. It's not common that you'll have that level, okay? And then of course your P6 is your brain dead patient, so it's going to again fall down to documentation. So when in doubt, either P1 or P2 are your most likely to use, because if it's not documented, it doesn't need to go further. Okay? Our next question, one of the codes questions had stated, and this is a connect wording issue, I want to say, but the question was, if you have multiple modifiers, you use modifier 99 for multiple modifiers apply. Now, what amount of modifiers is required for multiple modifiers to apply? And your options were 1, 2, 3, and so on. The answer to that is 3 or more. And I think that the problem is the wording in the book says 2 or more, but it in fact should be 3 or more. So this seems to be a connect issue, but one I wanted to bring up today because I wanted to talk to you. When you're listing a code, you can list up to 2 modifiers by themselves without needing any additional services. When you have more than 2 modifiers to a service, then you're going to need to indicate modifier 99, multiple modifiers, in order to identify that more than what we could list on the claim form applies. Okay? So I will be sending that particular one along with some of our other wording ones back to Connect to tell them, hey, fix this. And I'll also be reviewing over those on your grading, which is why there's a slight delay right now because I'm trying to get through all of those and make sure that I give you credit if you answered something based off of what the book said versus what it actually is. So I'm trying to get through all of those if you'll bear with me just a little bit. Last but not least, another question on our coding was questions on anesthesia, where maybe we entered a code and it marked it as wrong. Or maybe we entered a code with a modifier and it marked it as wrong. And the reason why these are marking it as wrong is because as anesthesia is a very unique circumstance, anytime, any code with anesthesia and anytime you have multiple units of something, you have to report it with the number of units. And anesthesia is always reported with multiple units. So in this case, you should have your code with your modifier and the amount of units that apply. And this was from the calculations last week on our calculation of time plus base plus qualifying modifiers. And so for every 15 minutes of time, you have 1 unit. Your base is specific to the code, and so you would look that up, and any qualifying modifiers. So depending on what applies, not in this case, this would not be a qualifying modifier. So let's say a patient had 30 minutes of time on anesthesia. That would equal to, for every 15 minutes, let's say their base was 3. I haven't looked up 900, so I can't guarantee that. But let's say it was. Then you would add 2 for the 30 minutes. Plus 3 for the base, and there's no, P1 has a 0 and there's no additional codes, so then it would be 0, and you would have 5 in this example that I'm showing you on the board. So if you answer, if your scenario was a 30-minute visit where anesthesia code 900 applies, modifier P1 applies, and keep in mind you also need who provided it. Almost forgot that one. So you're going to always have 2 modifiers, 2 mods, and units. And if you answered it with just 900 or just 900 with P1 and you did not put the additional modifier for who provided it and you did not put the units, then you're going to have that answer wrong. Now those are manual grade questions, so if you have this part of it correct or this and this part of it correct and you're only missing 2 parts, I'm going to take that into consideration when I put in the manual grade on those. So give me a little bit of time and hopefully I'll be able to have some grades on those by the end of this week, if not the first of next week. Well, that's all we had for today's Coding with Ms. Melanie coding segment for questions sent to me and reviewed specifically for class 2030. Until next time, have a great Valentine's Day.